Hello, everyone, and thank you all for tuning in to my last grand rounds as a resident, where I would like to discuss considerations in pediatric kidney transplant. I don't have any disclosures relevant. My objectives for the talk today are to review the preoperative evaluation of, from a urologic perspective at least, for kidney transplant in pediatric recipients. I'd then like to discuss the management of ureter and bladder abnormalities with relation to transplant, followed by technical considerations considering the size discrepancy that can exist between donors and pediatric recipients. And finally, I will plan to touch on transplant immunosuppression differences in the pediatric population. So end-stage renal disease in the pediatric population is relatively uncommon, especially when we compare it to the numbers in the adult population. These are Canadian statistics from the Canadian Institute of Health Information, CIHI, which represent an incidence of 14 children in BC with ESRD in 2022. Across Canada, this represented only about 75 children per year. It's important, however, that we address this topic in this population, as nearly all of these children will end up proceeding to renal transplant, as dialysis in pediatrics is really just viewed as a bridge to transplantation. And the reason that there is significantly less children with end-stage renal disease in pediatrics than in adults is represented here when we look at the causes for renal failure. In the adult population, we know that diabetes and hypertension are the leading causes of renal failure, and these don't exist to the same degree in the pediatric population. In the adult population, this is followed by glomerular causes, polycystic kidney disease, which is the most common inherited cause in the adult population. In children, however, the causes are vastly different. We don't see the hypertension or diabetes that we see in adults. What we do see are congenital abnormalities of the kidney and urinary tract, making up to 50% of all causes. These can include renal aplasia or hypoplasia, urinary obstruction from the ureteropelvic junction obstructions to vesico-ureteric reflux, posterior urethral valves, neurogenic bladder. Combined, these are the leading causes for chronic kidney disease in children. Other causes do exist: cystic kidney diseases, multicystic dysplastic kidneys, hemolytic uremic syndrome, or FSGS is another important one to think about because of the high rate of recurrence in the allograft of up to 20%. Overall, urologic causes do make up a significantly greater proportion of pediatric end-stage renal disease. And therefore, I think it's important for us as urologists that we have a good understanding of these conditions and involvement in the management of transplant patients. So here, I just wanted to highlight the overall improvement in outcomes in pediatric kidney transplant that has developed over the past few decades. We know that living donor kidneys are the ideal allograft in the pediatric age group, as these children are expected to have long-term survival and thus likely to require subsequent transplant at some point in the future. So if we can maintain graft function for as long as possible, we can reduce the burden of multiple repeat transplants. These figures represent the increasing rates of graft survival in each of the last 3 decades for both deceased donor and living donor pediatric renal transplants as a result of improvements in immunosuppression and the surgical management of these patients. From a urologic perspective, the pre-transplant evaluation surrounds evaluating for the cause of ESRD. And certainly if it's urologic, then we recommend further evaluation of the urinary tract prior to transplant. But at a minimum, all patients should at least receive a renal ultrasound as well as a post-void residual volume to screen for underlying urinary dysfunction. If there are no concerns here and no risk factors identified, then further evaluation may not be required. However, if there are risk factors, this can be recurrent UTIs, congenital uropathy, voiding complaints or dysfunction. All of these should undergo additional evaluation with a voiding cystourethrogram. And based on this initial workup, urodynamic testing may also be required to ensure that the bladder has adequate compliance and capacity to safely accommodate the transplant kidney. The most common abnormality associated with ESRD are that of low capacity, hypercontractile, and poorly compliant bladders, which can be dangerous to transplant a kidney into and may contribute to increased graft loss. The risk of recurrent urinary tract infection is also important, as we know that transplant pyelonephritis can cause morbidity in an immunocompromised host and lead to graft loss as well. So this kind of evaluation really mirrors how we approach pediatric urology in general, where we think about perhaps the storage and emptying capacity of the bladder. With the concerns regarding failure to store, we may consider additional treatments to optimize them pre-transplant, including anticholinergics, Botox, CIC, or bladder augmentation in severe cases. Failure to empty may require alpha blocker therapy, CIC, or in the sensate patients where CIC is not amenable, consideration for the creation of a continent catheterizable stoma, such as a Mitrofanoff. And finally, it would behoove me to mention that assessment and management of bowel and bladder dysfunction is paramount to the success of any of these additional treatments before and after transplant. So this was a commonly cited study that I came across from the University of Miami, published in 2020, that divided their 112 pediatric kidney transplant cases into urologic or non-urologic causes for ESRD. They hypothesized that the urologic group should have improved graft survival due to the risk of disease recurrence in the non-urologic group, such as FSGS. In this cohort, they had a median graft survival of 12 years, and the baseline variables did suggest that the pre-transplant UTI was a more common occurrence in the urologic group than the non-urologic group, and this correlated post-transplant as well. Interestingly, however, if you look at the Kaplan-Meier curve on the top right here, they did not find a difference between overall graft survival between urologic and non-urologic causes for ESRD. What they did find, however, was that there is an increased rate of graft loss for those who developed urinary tract infection following transplant, particularly the non-urologic group. And this really highlights the importance of preventing the risk of UTI long-term, particularly after transplant. So when do we consider pre-transplant nephrectomy? In general, maintaining the native kidneys is beneficial, as it can help with easier fluid management while on dialysis and for production of erythropoietin, vitamin D metabolism. However, there are certain situations in pediatrics where native nephrectomy may become necessary, including difficult to control hypertension, nephrotic syndrome causing profound proteinuria with malnutrition and coagulopathy ensuing, significant polyuria, any space issues related to making space for the allograft in the abdomen, or for peritoneal dialysis even pre-transplant. Typically, this may be the polycystic kidney disease patients, but there are other concerns too, especially in younger children where the space may be more limited. Finally, hereditary conditions that may pose a high risk of renal malignancy, such as Denny-Drash, where about 50% risk of Wilms tumor exists, may be considered for nephrectomy prior to transplant as well. There's some chronic or recurrent urinary infections. Large stone burden could be indications. In some cases, at least locally, we do consider unilateral nephrectomy performed pre-transplant at the usually at the request of the nephrologist to reduce proteinuria But in these patients that may not be on dialysis, we may be able to remove one kidney and still optimize their proteinuria while keeping them off dialysis. And one consideration to think about through all of these indications is the timing and the approach of the surgery in terms of the need for discontinuation of peritoneal dialysis, which is the preferred method for dialysis in these patients, as it would require time off of dialysis if a transperitoneal approach is utilized. So in pediatrics in general, there really are few absolute contraindications to renal transplant. As I mentioned earlier, we view dialysis as a bridge to transplantation, especially in this group. Most, if not all, contraindications are relative and require being addressed and optimized before a child can then be listed for transplant. These can include infections or inadequate emptying or storage parameters, which can be medically or surgically optimized prior to transplant approval. Social or financial issues should be addressed. These can affect the ability to maintain immunosuppression or the long-term follow-up required for transplant patients. And with regard to malignancy concerns, I just wanted to highlight within our the pediatric malignancy topic that for children that have Wilms tumor, they can still receive transplant, but this requires at least a 1-year follow-up for disease-free waiting period prior to approval. Now, this slide is just to really emphasize the impact that end-stage renal disease has in children who are growing and developing. Children on dialysis can have several standard deviations below their peers for height as a result of impaired growth from mineral bone disease associated with CKD. There are significant cardiovascular concerns, and the leading cause of death in the pediatric group is still cardiovascular disease, as it is in the adult population as well. And there's a burden of psychosocial development that can impact their long-term ability to function and contribute to society. Now, in the allocation for standard criteria donors in our local setup, there is pediatric recipients do receive higher priority. If we look here, this was a meeting in 2006 where standardization of the criteria for allocation were discussed across Canada, and pediatric recipients were given high priority, as well as high priority given to younger donors donating their kidneys to pediatric recipients. So I did want to move on now to discuss management of ureteric and bladder abnormalities that are related to renal transplant. Over time, looking at the posterior urethral valve bladder, these can be difficult patients to manage as they have complex considerations. The valve bladder over time evolves from that of initially a hypertonic, overactive, and poorly compliant bladder to later myogenic failure with hypotonicity, increased bladder capacity, and an elevated post-void residual volume. And while this is more of a failure to empty at this stage, the bladder pressures can be lower and therefore of lower risk to impairment to the allograft. When we compare the posterior urethral valve bladder, often in the pre-transplant state where we see patients that are anuric or oliguric, we know that they have a small bladder and they may have a difficulty initially in the postoperative transplant period. But and it can look maybe similar to the valve bladder, but in fact it is quite a different disease pathology where the valve bladder itself has had long-term remodeling and changes that make it quite different from those typically seen in end-stage renal disease. So it begs the question of whether anything should be done differently in this group. Typically, bladder augmentation is something that's considered as for the more severe reasons for failure to store. This review looked at some of the considerations for augmentation cystoplasty, comparing the benefits of doing this pre-transplant or waiting until after transplant to perform this in those patients that may require it. In the pre-transplant setting, the arguments may be that it may minimize the postoperative infectious complications related to the surgery while being on immunosuppression, and that if it's performed prior to transplant, then there's decreased risk of injuring the allograft at the time of the augmentation cystoplasty. However, there are numerous disadvantages to this approach, and may be preferred to delay the augmentation cystoplasty in patients that require it. As we know that there's a UTI risk related to augmented bladders, especially with the mucus production, and in those with oliguric or anuric states. There's significant risk related to metabolic complications, especially in the setting of renal failure. It may preclude patients from receiving peritoneal dialysis due to the augment. And there's risking of injury to the augment pedicle at the time of transplant as well. And finally, I think the crux of the question here is whether these patients really do need the augment after transplant. As I mentioned, and I'll show on the next slide, these valve bladders do change over time as a result of the natural history. This same study looked at a number of papers that presented urodynamic data in non-augmented patients. And what they found overall was that there were improvements after transplant based on urodynamic findings for improved capacity, as well as compliance within these bladders without the need for augmentation. And this really begs the question of whether we can consider, in very rare cases, performing augmentation in the pre-transplant state. But the authors do suggest overall that we should really rarely consider this. And in fact, performing it after transplant is probably the safest way to approach this. Now, we did talk about augmentation for that of failure to store, but failure to empty is a different issue. And in these cases, especially in the valve bladders, where they have a sensate urethra and high bladder neck, the ability to perform CIC is limited, and therefore Mitrofanoff augmentation is often a pre-transplant event. This is a retrospective review from the Toronto group, where they reviewed all their pediatric transplants and identified 22 patients that had sufficient follow-up data who had posterior urethral valves as a cause for their renal failure. In this cohort, they performed pre-transplant Mitrofanoff in nearly 41% of patients, and none of them required a Mitrofanoff post-transplant. There was also concomitant bladder augmentation performed in 22% of them. The interesting comparison that they make here in their study was that those requiring those that received a Mitrofanoff progressed to dialysis significantly later than those that did not have a Mitrofanoff, at approximately about 10-year difference. And they suggest that the ability to perform CIC via the Mitrofanoff may have delayed the onset of renal failure. But I find this difficult to really make any real comparison or statements on, given the retrospective nature of the study. And it may, in fact, just represent differences in the severity of those underlying patients' progression to renal failure. Overall, what they did show, though, was that similar outcomes existed between these two groups in terms of complications, acute rejection episodes, and estimated GFR, with a follow-up at just over a year, with only one episode of graft loss in the Mitrofanoff group. Looking at complications following transplant regarding the ureter, this was the largest study that I found in the literature looking at ureteric obstruction following a pediatric renal transplant out of the group at the University of Minnesota. They had a series of 526 renal transplants who were followed with a mean follow-up of 8 years. And they looked at multiple variables for causes of ureteric obstruction. And their definition for that was that which required intervention, either PERC nephrostomy, stent, dilation, or ureteric reimplant. And amongst all of those variables, the only one that they found that was significantly different was the presence of posterior urethral valves. And it had a 7.5-fold increased risk for ureteric obstruction at the ureterovesical junction. They hypothesized this was a result of avascularity of the detrusor, thickened bladder with a lot of collagen remodeling as the proposed reason for this. And I will touch on this kind of issue of whether a ureteroneocystotomy, the standard approach for implanting the ureter on the bladder, whether there may be other considerations to prevent this in these particularly difficult bladders. But before I get there, we do know that as a complication following transplant, vesico-ureteric reflux is something that can be found incidentally in a number of patients, but we really only care about reflux into the transplant kidney if they're symptomatic from this, i.e. whether they're having infections. The standard approach would be to manage bowel and bladder dysfunction first, followed by consideration for prophylactic antibiotics and perhaps ureteroneocystotomy or a reimplant in select patients if they have symptomatic recurrent UTIs as a result of VOR. With the use of deflux, however, in the standard pediatric population, there's been questionable whether this could be applied for reflux in the renal transplant literature. This was a meta-analysis, or rather a systematic review that was performed of 6 studies that met criteria in the pediatric transplant literature, including just 67 patients in total. And their definition for VUR was based on voiding cystourethrogram, and both pre and post deflux. And what they found was the success for deflux was really quite poor in this patient population of only about 37%. Additionally, 10% of those cases ended up having ureteric obstruction as a result of deflux, and 4 of them needed a ureteroneocystotomy for management. When they looked at their cohort of overall 67 cases, 20 patients still had persistent vesico-ureteric reflux to the transplant kidney with urinary tract infections, despite the deflux, and they required further treatment with either prophylactic antibiotics, or the majority went on to have ureteroneocystotomy. They also did make a comment, although there wasn't a formal evaluation, but a comment regarding the same use of deflux in the adult patient population, which I thought I would touch on briefly. They found 5 studies, and in this cohort, they did seem to suggest slightly higher resolution rates for vesico-ureteric reflux in the adult population. However, their definition for success did vary across these studies, as well as their injection technique, including subureteric or intraureteric, as well, didn't appear to affect the success rate. Overall, in the adult population, it did appear that the success was greater in those that had lower grade non-dilating reflux. So finally, this goes back to the point I made earlier about the difficult valve bladders. The group at the University of Toronto has suggested that a primary UU, or ureterosterostomy, to the native ureter may be a reasonable approach in particular patients that may have a small hypocontractile bladder, or in the valve bladders or neurogenic bladder patients, to avoid potential complications at the ureteric implant site. This was obviously a retrospective study where they included the 25 patients they were able to perform UU on, compared to those that had 188 of those that had a ureteroneocystotomy. What they didn't do, though, is look at complication rates of their own cohort within the ureteroneocystotomy. They only were able to compare it to that of other studies. So I think it's quite a limited study. But overall, their success was determined by the reporting of complications, of which they only dictated 2 patients developed a urine leak, one of which required just a prolonged stent and recovery. The other required a further balloon dilation of the anastomosis and then further stenting. But it does raise it as a possibility for, or at least a consideration for those where the bladder may be very small or difficult than anticipated. It does seem that there's at least a reasonable option to consider a primary UU for these patients. So I'll now move on to consider to discuss some of the considerations related to size between the donor and the recipient. In the adult population, just to kind of frame things, we often perform, obviously, most people have experience with this, but we perform an extraperitoneal approach via a Gibson incision, where we're able to put the kidney in the retroperitoneum and anastomose the vessels to the iliacs. In the pediatric population, this is still preferred, but it may be difficult in those that are under 30 kilograms, where we have to consider the size discrepancy between an adult-sized kidney going into a small pediatric body. And in this case, we may have to go higher in order to perform the anastomosis. There's also considerations regarding the size of the vessels. For example, the donor renal artery from an adult can be similar in size to the aorta of the recipient, and the IVC from a donor, or sorry, the IVC in a pediatric group in young or small weight infants can be much smaller than the donor renal vein. So there are some technical considerations here. Some below the kind of size of 10 or 15 kilograms is where these become quite low weight. And there does need to be a discussion at each of the transplant centers regarding the approach, where some people favor an intraperitoneal midline incision, whereas others still attempt to perform an extraperitoneal approach and perhaps consider doing native nephrectomy in order to create further space in that setting. This was one of these studies that looked at, from Tokyo, that looked at their outcomes with living donor kidney transplant in children less than 15 kilograms. They compared the intraperitoneal approach with an extraperitoneal approach with a median follow-up of 14 years. But it's important to note that even the baseline variables for both age and size or weight of these recipients were different between the two groups, which already suggests that there was a bias surrounding which patients had a feasible approach for the extraperitoneal. But overall, they did suggest that the long-term graft survival between the two in this cohort of limited numbers, it was about 100 patients total, was similar out to 10 years. What they did show, however, was that the intraperitoneal approach had a significantly greater risk of surgical complications related to the urinary tract, the bowel, as well as anastomotic complications such as thrombosis, bleeding, and a few episodes of renal allograft compression, which required further intervention. And so, although the approaches do have similar graft survival outcomes, there's a significantly greater risk of complications in the intraperitoneal approach, at least in their cohort. But it's likely a result of selection bias between these two groups and the feasibility of an extraperitoneal approach in very small children. We actually, there's actually a publication from 2006 from our local experience here at the BC Children's Hospital, looking at the same population of children less than 15 kilograms and over a 20-year period. And actually the approach here at BC Children's was described as almost all children able to receive a extraperitoneal approach for transplant. Most of the anastomoses were performed to the iliac vessels. And in terms of their outcomes, overall, their outcomes were, with a mean follow-up of just under 80 months, were quite excellent when compared to the national database across North America, with 5-year patient outcome survival, of 88% and graft survival of 92%. in their experience. Now, vascular thrombosis is a significant concern, as it's a cause for graft failure in up to 10% or even greater in some series of cases. And so this was a large data set from the US renal data system that evaluated the potential risk factors for vascular thrombosis in the pediatric transplant literature. They looked at over 14,600 kidney transplants over a 20-year period. The overall incidence of vascular thrombosis was just under 1% in the second decade of their study. And when they looked at a number of different variables, age of the recipient as well as donor, different donor characteristics, and a number of others, what they ended up identifying as the increased risk factors for allograft loss as a result of thrombosis were the use of en bloc donor kidneys with the greatest risk, as well as increased cold ischemic time over 12 hours. And as a result, we actually in the pediatric group don't utilize en bloc donor kidneys as a result of their significantly higher risk of vascular thrombosis. And I'll touch on that in just a moment. So it begs the question about what can we do? Obviously, surgical technique, meticulous surgical technique is very important to preventing thrombosis, as well as the selection of appropriate donors for the pediatric age group. When we think about other things that we can optimize, though, often the question comes up regarding antithrombotic prophylaxis. And there have been a number of studies on this, and a meta-analysis here was performed across the adult and pediatric literature to evaluate this question. However, there's significant heterogeneity across these studies, and some of them used low molecular weight heparin as the prophylaxis. Others used unfractionated IV heparin. Others reported using aspirin. So there's significant differences in terms of the medication, as well as the duration from 7 days at post-op to 30 days post-op, or 3 months, some of them. So there's variation in terms of how they employed this prophylaxis, and it's difficult to kind of interpret the results as a result of this. What they did show in the pediatric group studies was that there was a favored benefit towards antithrombotic prophylaxis of some form relative to doing nothing. But the question about who to kind of select this for is raised. The authors did propose a number of risk factors for thrombosis that you can see here, and propose that those that are in an intermediate or high thrombotic risk may be best considered for prophylaxis. In the adult literature, as you can see, the confidence intervals are much wider and across all over the place, and so as a result, the overall result in this population was that there was no significant difference. The important question that I asked and looked through this was about what are the potential risks of giving heparin or aspirin to these patients, whether that's bleeding risk or the need for reintervention. And all of these studies had variable reporting of this, and so they were actually not able to answer that question in this meta-analysis. Another important consideration that we need to be aware of, but also as a team involved in pediatric transplant during the perioperative care, is the importance of maintaining intravascular volume. This was an interesting study. It's quite old now, 1998, but it was an interesting technique where they identified that between an adult donor and a pediatric recipient, the pediatric recipient is able to only maximally meet about 2/3 of the renal blood flow that kidney had seen prior to transplant. So what they did in this study was they used cine phase MRI to measure arterial blood flow, both in the donor and the pediatric recipient after transplant. And in the donor before transplant, the renal artery blood flow was over 600 milliliters per minute. And in the pediatric recipient after transplant, the renal artery blood flow only maximally was 300 to 400. So up to 2/3 of that was seen in the donor. And what the point that this makes here is that in the pediatric group where we're seeing an adult-sized kidney going into a pediatric recipient, they're already at a higher risk for low flow states. And so anything further that we do, whether that be intraoperatively or postoperatively with any episodes of hypotension, can put this allograft at further risk for low flow states and potentially ATN, thrombosis, or primary non-function. Now, the final kind of technical point regarding size considerations that I wanted to touch on was the consideration of en bloc kidneys. As I mentioned, we don't use these in pediatrics anymore, but this was a study in the adult literature that suggested that they may still be a viable use in the adult population, where the risk of thrombosis is lower than in the small pediatric recipients. They studied, I think they had about 70 to 75 patients in each group, where they received either a en bloc deceased donor kidney or a living donor kidney. And their overall graft survival was quite similar between these two groups, which is impressive given that the en bloc kidneys are donor. But there is some evidence that en bloc kidneys can grow with time when put into an adult recipient, up to 3 times in size within the first 6 months. And so it may still be a consideration for select adult patients. So finally, I'd like to kind of highlight some of the differences that we see in considerations with regard to immunosuppression in pediatric patients. Just as an overview, we know that the immune system develops from birth into adulthood, and over this time, we do see a number of changes, particularly in the younger age group. There's a decrease, or at least less number and different subtypes of T and B cells that are responsible for the alloimmune response. And there's also a difference in their expression of particular proteins. And so the immune system can be quite naive earlier in life and develop later. So what we see, what I wanted to highlight here was that in a study looking at different age groups of graft survival for living donor kidneys, we see that the age group between 1 and 5 years of age has the best overall outcome with living donor transplant, and that this tends to drop off. A lot of people think that this is due to the fact that when you put a kidney into a very young neonate, that their immune system may not be strong, and so you get less reactivity as a result. The kind of trade-off is that if their immune system is weaker, that they end up having a potentially higher risk for infections, particularly the viral infections that we see in transplant. The other interesting point here, if you look at the yellow bar, is this teenage cohort, which appears to be lower than both the pediatric and adults on either side with time. And one of the hypotheses to this is that in this teenage cohort is when we start to see more medication non-adherence, which can contribute to graft loss, but also that perhaps at this age group the immune system is quite strong, and so you're seeing increased reactivity. Just to briefly kind of provide a summary of the overview for transplant immunosuppression, where we have both induction and maintenance phases to work with. The induction phase of immunosuppression consists of methylprednisolone, and predominantly in the pediatric group, basiliximab, where ATG is rarely used. And in the maintenance phase, there's corticosteroids, calcineurin inhibitors, typically tacrolimus, as well as the antimetabolites, typically mycophenolate. This was a summary of the timeline of different immunosuppression protocols over several decades. collected by a large North American collaborative group. And the big things to highlight here are that over time, there tended to be a change away from cyclosporin in the triplet maintenance immunosuppression towards tacrolimus. And the other important point is this steroid-sparing regimens were quite rare initially, and now are now being utilized a lot more in the pediatric group. The reason for this is that we know that steroids have significant adverse effects, and particularly in the pediatric group, the significant concerns are related to growth, where we know that the patients on dialysis already are set to have impaired growth. And then if we went after transplant, we provide them with ongoing steroid immunosuppression, that they don't experience the catch-up growth that is necessary in order to meet the growth of their peers. There's also a number of other appearance-related obesity factors, as well as psychiatric illness, all of which can contribute to provide reasons for medication non-compliance in this group, which is already a large issue and a significant contributor to graft loss. So minimization of steroids has been of interest, particularly in the pediatric group, in order to address these issues. And there are several different ways that this can be employed in a transplant program. The question really, though, that is brought up with regard to this is which patients may not be eligible for steroid-sparing regimens. Typically, across the number of studies here that I've shown, they include they tend to exclude, rather, or at least underrepresent patients that have higher immunological risk for obvious concerns. And these features may be higher PRA, HLA mismatch, presence of donor-specific antibodies, ABO incompatibility, those that have delayed graft function of African American race, or repeat transplant patients. And the other group is those that have high risk of disease recurrence in the allograft, such as FSGS. Now, just going back to this slide here, across historically, steroid sparing in pediatrics was something that was rarely considered, and a lot of people still have concerns regarding it and the potential risk for acute rejection, as the earlier studies that were performed towards the beginning with different immunosuppressive protocols did suggest that there's a slightly increased risk of acute rejection using steroid-sparing protocols. However, in the more modern contemporary series that have looked at more modern immunosuppression with tacrolimus and mycophenolate, these concerns have been reduced, where we're not seeing significant differences in rejection, graft survival, or patient survival, but that there are significant improvements in patient growth and other cardiovascular risk factors. And so I believe in the last number I saw was in 2019 across all transplant programs in the North American collaborative group. It was about 40% of pediatric patients that were receiving steroid minimization strategies at that time. Now, as we see changes in other approaches that are coming down the pipeline in transplant immunosuppression, including minimization of calcineurin inhibitors, or the utilization of other induction agents such as belatacept, we have to consider how to incorporate these protocols in all of these new developments going forward. And up to date, there haven't been inclusion of pediatric patients in these studies, but hopefully going forward, we can see that to allow these changes to overlap into the pediatric population. So I will finish there, just to kind of summarize a few take-home points, if I can, just to highlight that pediatric patients really have different causes for end-stage renal disease than the adult population. And the majority of these are of urologic etiology. So it's of critical importance that urologists remain involved in the evaluation and the management of these transplant patients in order to improve outcomes. And ultimately, as a result, a multidisciplinary team really is critical to the success of pediatric transplant overall, as these can be complex patients, complex surgical considerations. And so we really want to load the boat with all the providers that can help optimize the success long-term. So thank you very much. I just wanted to highlight that Dr. Delis Reyes, Dr. Afshar, and Dr. McNeely provided support in preparing for this presentation. And I welcome any questions.